Good morning, everybody, and thank you, Dr. Pramod and team, for organizing a fantastic event and throwing show there. I think mine is more like a summation of what we have seen the last few days. So I've just run through it, so that was just to summate and then to familiarize things. So MI is basically surgically the same thing which you're doing in open, but it's more in a closed portal, avoiding collateral damages and negligible repairable problems. It's not about making a very small incision, but achieving the targeted surgery with the least amount of problems and complications. It requires technology, allows us to work and visualize the spine through the small portals. So when you look at indications, I've not specifically put down the list because everything is now doable under MIS. So what are the various common surgeries we do? Microdiscectomies, laminectomies, kyphoplasties. We've seen through the whole list across in this. Now, few examples we're looking at it. We look at that. We have either could be a minimally invasive anterior approach or anterolateral approach, or it could be a thoracoscopic approach anteriorly, or it could be a use of tubular retractors anteriorly or posteriorly. When you do posteriorly, commonly it's for thoracic decompressions, stabilizations, fractures, plasties, or endoscopically demonstrated in the thoracic spine as done by our Korean friends. Now look at the mini thoracotomies. It's done from T4 to L1 and L2. It's through a small incision to a tubular retractor. Degenerative pathologies, traumatic injuries, infectious processes, neoplastic processes, all these can be addressed as seen by various authors. Small example here of a fracture here which is done there. What can be done or what was done, a small incision, 5 centimeter incision through which you could go ahead and then do a corpectomy or an instrumentation. This can be done using one of these retractors, or even otherwise, if you don't have the facility to do it, use a Hohmann retractors, and can be done in an elegant manner, putting in a cage as well as these screws across. Now, contraindications which are relative could be previous surgery, history of pneumonia, emphysema, obesity, pathologies in the posterior part of the canal and the spinal column itself can be a contraindication. Advantage is small size, reduced trauma, less risk, and deflation lungs is not necessary. We're doing it at a lower level as compared to the higher level. A long learning curve, multi-level pathology is difficult to intervene, and viewing the results is also a little difficult as compared to a large open surgery. Now, when you go on to minimally invasive decompressions or surgeries, you use tubular retractors, which could be of two types, a fixed or an expanding blade. Based on skin design, excellent retraction. It's a challenge working down a narrow tube, and you have to get used to this. The expanding blades could be bulky, little obscure on the X-ray. Muscle creep can be there. It confines to irregular bony anatomy and easier to work though. So going on to a thoracoscopic, Peter Newton as well as others have shown how wonderfully they could do a major reconstructive work with a thoracoscopy or VATS procedure. I have had experience with a couple of surgeries, but not much, and I wouldn't want to venture into it without experience. So indications again could be various things: the tumors, the deformities, interbody fusions, inflammatory states, etc. Positioning and setup, I'm not going into it. Contraindications would be severe cardiopulmonary disease, acute traumatic lung failures, or hemostatic disturbances are contraindications towards this procedure. The advantages would be that you have an intercostal approach, no need to do a wrist resection, soft tissue trauma is reduced, is very safe, and anti-decompression is pretty safe. And treatment of multi-level pathologies can also be done. However, it's increased anesthetic exposure, technically demanding, and learning curve is very high. Posterior approaches could be due to a mini-open technique, where you have instrumentation, but fascia opening is only over the corpectomy side. The tubular retractor is used, preserves the rib head and avoids pleural dissection, reduces risk of pleural effusion as compared to that. So when you go on to pedicle screw fixations, again, everything is gone through on this. It can be done either by a direct approach or by Wilsey approach. Indications, again, everything is an indication now to do NMIS. Contraindications would be severe osteoporosis, relatively now, against previous laminectomies or a very poor surgical candidate. Advantage is very similar. Lastly, going on to some thoracic levels, vertebroplasties or kyphoplasties, centroplasties, muscleplasties, these are current things that are being done to reinforce our osteoporotic vertebrae. Augmentation of these can be done in myelomas or osteomyelitis or in trauma itself, and you want to do combined procedures, and these could be very helpful in doing these procedures. Percutaneous endoscopic thoracic discectomies have been done, as well as decompression done. We saw Dr. Kim and the team showing it from Korea. Of course, wonderfully done. And it gives you the three-dimensional view of what can be done across. Avoids dissection on the vulnerable structures, reduce retraction of neural ligaments. Of course, anatomical familiarity is needed in these techniques. Thank you very much for the hearing.